Since I plan on being a neonatal nurse once I graduate nursing school, I chose to do the case study on the infant with hypothermia. The neonatal transport team was called to transport a 3-day-old male infant who had stopped nursing and became jittery and hypothermic. The patient was doing very well until early on day 3 when he stopped nursing. He was supposed to be discharged to home later that day, but his father noticed noisy breathing and grunting. His physical examination showed hypertonia and jitteriness involving all 4 extremities. His rectal temperature was 36.5 degrees Celsius. He had also lost 270 grams of weight since birth. By the time the neonatal transport team had arrived, he required supplemental oxygen of 35 to 40%. His heart rate was 170 to 180 beats per minute, and his lungs sounded wet. An orogastric tube was placed, and 5 milliliters of fresh blood was suctioned from his stomach. It became evident that he had suffered from a severe pulmonary hemorrhage. Hyperammonemia is often the sign of an underlying metabolic disturbance. Normally, excess dietary and waste nitrogen, which remain after protein synthesis, are converted to urea through the urea cycle. According to Burton B., disorders of the urea cycle enzymes lead to accumulation of ammonia and its precursors. This can lead to encephalopathy and death, or devastating neurologic problems, if not treated promptly. According to Oskey F., Principles and Practices of Pediatrics, the severe form of transient hyperammonemia in the newborn occurs most commonly in premature infants, often in conjunction with respiratory distress. Hyperammonemia may cause central hyperventilation, resulting in respiratory alkalosis. This can also be an early warning sign of the urea cycle disorder. Hyperammonemia is a medical emergency. The longer the patient remains in a coma due to hyperammonemia, the worse the prognosis. Prior to transport to a tertiary care center, endotracheal intubation may be necessary. The placement of the central line, such as an umbilical arterial or venous catheter, may be helpful in management of fluids, acidosis, and supporting blood pressure. The next goal is to remove oxygenous propane. Hemodialysis is the only means of rapidly removing ammonia from the body. Peritoneal dialysis does not remove ammonia quickly enough to minimize brain injury. While preparing for hemodialysis or extracorporeal membrane oxygenation, ammonia scavenging therapy should be initiated, even prior to the diagnosis of specific metabolic etiology. If it is felt that alteration of the central nervous system status is secondary to the high ammonia level, parenteral nutrition is needed to prevent protein catabolism. Using glucose and intravenous fat emulsion without protein to maximize calories. Once the ammonia level is higher than 100 and the patient is stable, oral or nasogastric feeding tubes may be initiated using a protein-free powder. Without protein, the body goes into a negative nitrogen balance, which increases the need for nitrogen excretion and worsens the hyperammonemia. There are 3 parts to maintenance therapy: protein-restricted diet, supplementation of citrulline proarginine, and medication, which provides an alternate pathway for waste nitrogen excretion. The specifics of treatment depend on which enzyme is deficient. Currently, the only way to correct the enzyme deficiency permanently is liver transplant. Survival and neurologic problems depend on the length of the hyperammonemic coma. If the coma is less than 2 days, there's a chance for minimal problems, but neurologic defects usually occur when the coma is longer than 2 days. Many who survive may have neurologic problems, mental retardation, seizures, cortical atrophy, and spastic quadriparesis. Later, acute episodes from protein intake or infection can result in further morbidity and death. According to Burton B., few patients with urea cycle deficiency live into adulthood.